Hey everyone, my name is Fareed Riaz, and welcome to tonight's SIR Resident Fellow and Student Section webinar. So as you all probably know, we hold these sessions about every 2 weeks or so. So thanks for showing up. If you've got any questions during the talk, feel free to type them into the chat box or the questions box. Lindsay, who I'll introduce in a second, will go ahead and field all those to the end, but feel free to ask them at any time during the presentation. And then it's my pleasure to introduce Lindsay Carr, who will be introducing our speaker for tonight.
Hi, everyone. Can you hear me, Fareed? I'd like to introduce Dr. Suresh Vedantham. Dr. Vedantham has engaged the SIR-RFS in the past, and so we're very happy to have to welcome him back tonight. Dr. Vedantham did his residency at UCLA and his fellowship at Stanford, and now holds a faculty appointment at Mallinckrodt Institute of Radiology at Washington University School of Medicine in St. Louis, where he's the national principal investigator for the ATTRACT trial. He has many publications, a large amount of which focus on DVT, and he's also been featured in Endovascular Day and the IR Quarterly for his work in the ATTRACT trial. So without further ado, I'd like to introduce Dr. Vedantham.
Thanks very much. It's my pleasure to be here and speak to you again. And I want to sort of thank the Resident Fellow section for all the hard work it's done to advance our field, to advance education in our field. It really is an important, very important thing to do. So thank you so much for all that work. As you can tell, I'm a little bit under the weather, and so my speaking voice is not what it should be. You will hear me cough. You will hear me drink water. But we will get through this, and you know, it's really a pleasure, and I'm excited about the fact that some of you are willing to hang on an evening and try and kind of prepare yourselves for your futures. So today we'll talk a bit about developing the mindset of a clinical investigator, and this is kind of a topic that as the years have gone by, and I've had the opportunity to be mentored by sort of senior clinical trialists over the years, I've learned quite a lot about, and so much of what I understand now, I wish I knew about 15 years ago when I was just starting out. But in any case, I'll give you first, try and page forward, here we go. My disclosures here, just research support to my university from a number of entities there. I'm also serve in the role of secretary for the Society of Interventional Radiology, and I'm a board member for the American Venous Forum. So objective, kind of learn the key characteristics of a well-conducted image-guided intervention study, be able to assume the posture and mindset of a rigorous investigator, and creatively adapt to real-world issues that arise in the course of conducting studies. So I think the first thing, and this gives you maybe a little bit of background on myself and my perspective, you know, what's possible for an IR researcher? Well, I think I would say at this point, anything. It's very important to keep in mind that, while you may have some idea of what type of practice you're going to be in and what type of researcher maybe you're going to be, the opportunities are quite broad, actually, and you know, you should be really open to kind of following your interests, and don't assume that you can't find a way to do what you want to do in whatever clinical setting that you're in. To give you a little bit of background about myself, I never would have expected to be an NIH researcher going into medicine. I was interested in research, but I was trained as a doctor, like most of you probably. No special training in research, no PhD, nothing like that. And over the course of involving myself in the care of patients with deep vein thrombosis, ultimately we ended up proposing a big NIH trial and successfully got it funded. That was in 2008, the ATTRACT trial, and that's a big sort of paradigm-changing randomized clinical trial looking at the use of catheter-directed thrombolysis in patients with DVT, and the results of that trial will be out in about 1 year. Now, the interesting things about this are that the directions it's taken me afterwards have just been utterly shocking. There's another series of trials that are really following on the ATTRACT trial, led by some by myself and some by other investigators. The FLOW study is looking at pediatric DVT thrombolysis. The CTRACT study is looking at chronic DVT. The PTRACT study is looking at pulmonary embolism thrombolysis, and all these are the subject of very serious efforts to obtain funding from the NHLBI. Some of them have been funded by NIH in terms of planning a planning process. And I think that also what I've learned is I've been pulled into all kinds of opportunities to help others learn how to do multi-center clinical trials. Again, things I never would have imagined. I've also been asked to be the administrative director of our Translational Thrombosis Research Center at Washington University. Again, very much unexpected because I don't really have a basic science research orientation, and so this has really brought me into contact with a lot of basic science researchers. And so I think that in terms of opportunities, remember, there are interventional radiologists that run basic science labs. There are people that focus in the computing world, biomedical engineering, in the newest sense, 3D printing. And then there are many, many interventional radiologists that are out in clinical practice who really enjoy the practice of interventional radiology, who participate in clinical trials. And that's a very, very important thing to do and to do well also. And so I would not think that the practice setting you get into needs to necessarily limit you in terms of what research you do. Other opportunities now, we're also running other kinds of multi-center trials in our ATTRACT unit, believe it or not. We have sort of built a little academic research organization here to run other people's trials. I've been involved with universities, research administration, and many other things. So again, really you can go in so many different directions. Now, how to prepare yourself for all this? Obviously, this didn't really come in a day. I think some of the key things, first of all, you've just got to indulge your own curiosity. You have to be passionate about the area that you're studying, and no matter how well-funded or well set up a project is, if your heart isn't in it and you don't care about it, the reality is that research often gets done in the weekends, the evenings. It's going to take your own passion, and that's going to mean a lot more, again, than what practice you're in or any other kind of limitation you might think about. I think that taking research education seriously, as those of you on this webinar are already doing, is very important, and in particular recognizing that, remember that for most of us with MD background, we're trained to be great doctors. And then as we enter practice, what you'll find is that you get a lot of positive reinforcement for being a great practice builder, which is another skill set. Now, being a great practice builder really involves establishing a certain kind of credibility and convincing people and referring physicians to want to have more procedures, right? I mean, that's really a core of it. And to convince them that the clinical work you're doing is going to help patients' outcomes. That's its own skill. Now, being a clinical researcher, when I started the ATTRACT trial, we thought, okay, well, there's these great people that are presenting at meetings and they're doing 1 million of these cases. For sure, they're going to be enrolling tons of patients in our trial. Well, nothing could have been further from the truth. Being an effective researcher involves a totally different set of skills that are just different than really practice building. First of all, you're really in a randomized trial, you're really not trying to encourage people to have procedures. You're trying to encourage people to look at the question in a balanced way and agree to randomly be assigned to either have a procedure or not have a procedure. That's a very different thing. That means you need to present the pros and the cons in a very balanced way. You need to be able to convince and teach your collaborators to do that as well. You need to be able to understand the mechanics of how patients enter clinical studies and set up your practice accordingly. You need to be able to talk to patients and help them become comfortable around research. And those are all very different skills, and a lot is written about those by people who are sort of PhD wonk experts in that particular thing. So keep in mind, it's a different set of skills. You want to keep developing them. I think another key thing, and I see this kind of flouted at times, is that you need to really embrace a hypothesis. And again, you need to recognize first and foremost that a hypothesis is an idea that could be totally wrong. We develop hypotheses to drive the construction of a study, but when we're doing a study, we're really not, I'm not doing the ATTRACT trial to prove that thrombolysis works. And if I went around and trying to convince collaborators to join me in something like that, what I would find is maybe a lot of interventional radiologists and some surgeons, but I wouldn't have many collaborators from the medical subspecialties. I wouldn't have a lot of credibility, and certainly we wouldn't have gotten funded by the NIH. So I think that the first thing is when you're talking about research, you're trying to figure out if something is right. And learning to think and speak in this way is really an important thing. And one thing I noticed during the ATTRACT trial, for example, is that many of our investigators that were great practice builders, the way they talked about the two different options about DVT treatment was, okay, well, I'd randomize you to treat, don't worry, you're going to be in the treatment arm, as if the other arm isn't getting treated. Well, the other arm is getting anticoagulation, which is actually the standard of care for DVT treatment. But as a proceduralist, we tend to think that treatment means doing the invasive procedure. And, so I think that in the way that that sort of comes out, and people will sense the bias, and patients will sense the bias. And so it's very important to learn to sort of think and speak in that way. I think that groupthink is a big thing to think about at an early stage in your career, to really develop the kind of balance and the sort of discerning sort of questioning that enables you to sort out nonsense from truth, or at least determine what we really know versus what we maybe think we know. And remember that each subspecialty thinks differently. And, so many things are different, that getting down to the basics. Our very concept of the pathophysiology of a disease is different. The clinical setting in which we see patients, an emergency room doctor sees patients with a new DVT, puts them on anticoagulation, and never sees that patient again. They have no idea what happens to the patient in the long run. On the other hand, if you are a vascular surgeon who works in a venous ulcer clinic, all you see is the end stage of venous disease, which only a minority of patients get, which is a bad venous ulcer due to post-thrombotic syndrome. And so the whole concept of that disease is so different for these different groups of physicians. We have to remember that, we have hammers in interventional radiology, and so everything looks like a nail. And everyone wants to believe that what we do is helping patients, and so you develop a kind of subconscious bias in favor of believing that what you do works. That's human nature. You have to remember also that the way, who funds our meetings, so, the places we interact really are supported by, for interventional radiology, mostly the device industry. For the medical subspecialties, is actually the drug industry. And so, which isn't all bad, because collaborating with others is always a good thing. On the other hand, there are obviously limits, and it's very important to realize that the thinking process can't be affected by that. Our job, we're doctors, and our job is really that we want what's best for patients, whatever it happens to be. And I think that in terms of researching and becoming a serious researcher in an area, you really need to be able to argue both the pros and the cons convincingly. And once you can do that, you're really ready to go out and find collaborators. Obvious solutions to groupthink. One is you need to know the literature, and know the literature means not just knowing what's in JVIR, which is a great journal, but it's very important to know the disease and know the literature of others that care for the disease. So the thrombosis literature for me, if you're interested in oncology, understanding the medical oncology literature around the treatment of hepatocellular carcinoma, for example, is crucial to really developing a balanced perspective on the use of image-guided procedures in that area. It's important to talk to different physicians and listen from the context of not just listening to their basic view, but listen to the language and how they talk about the disease. It's really mind-blowing to me how I can go to the SIR meeting and hear and talk with my colleagues about DVT. When I go to the American Society of Hematology meeting, we can have the same conversation about the same things, but it doesn't sound anything the same. We're just talking in different terms. And it's important to learn how a diverse group of physicians talk about the disease that you're interested in. Multidisciplinary mentorship, I think, is a big thing. I was incredibly lucky. I've shown you the pictures of some of the incredible people that have mentored me through the years. A couple of them, you see Mike Dake up there, Tim Murphy, our interventional radiologist. The others are not. And I think that as you specialize into an area of research, it's very important to find mentors, not just within but also outside IR. And in truth, one of the honest truths about IR is that there are a limited number of mentors that are serious researchers in the IR area. And so in addition to giving you a breadth of perspective on the disease, you're a little more likely to find people that have a more detailed understanding of research methodology outside IR at the present time. Hopefully, by the time you all are well ensconced in your careers, that will change. And again, all of this is important to learn how to communicate with different stakeholders that you're going to need to support your work. Again, give the example that I know best, which is DVT. When we think about the way an interventional radiologist looks at the problem, we think, okay, well, the veins are blocked, and that causes valvular damage, and that's what causes the patient's problems. But a hematologist actually looks at it totally differently. It's all about the biology. In other words, DVT is thrombosis. It's a field condition, and really where the clot is doesn't matter. What mattered is that the patient was more prone to clotting, and that's why they clotted. And what really matters is reducing their overall predilection to clotting with blood thinning drugs. And so the whole perspective is different. We use different terms. We have different experiences in terms of the manifestations of disease that we see, et cetera, et cetera. I'm going to keep on moving here, actually. So I think that, understanding the language is better. Here's a great example of multidisciplinary collaboration that, again, it's bumpy. It's really bumpy when you start interacting with physicians outside your subspecialty, but you grow much, much faster when you do. I think it's important to develop a reputation as a great mentee as well. And, oftentimes I think that when you're young, there's the common sort of talk about, well, how do you find a great mentor? And I think half the answer is, how do you make yourself a great mentee? Because mentors respond to great mentees, and I think that a lot of it is if you're dependable, if you're organized, if you communicate frequently while still respecting your mentor's time, and if you follow up with that mentor in terms of how you followed their advice. That's such a crucially important thing to do. And even when you don't follow their advice, even when you make a decision that's, well, I don't think that's the right way to go, if you get back to them and say, you know what, I gave careful thought to what you said, I talked about it more, I thought about it more, and I thought maybe this is a better way to go, people appreciate that tremendously. It shows maturity, it shows seriousness of thought, and one thing is just that continued follow-up with your mentors is an important thing to do. And I've been so lucky in the sense that I lead the steering committee of this study, and pretty much everyone on that steering committee is older and more distinguished than I am. But that said, they've been willing to follow my leadership, and I think part of that is, as well as being sort of a leader, I'm also have been as good a mentee as I could figure out how to be. So we'll talk a little bit now about study-specific preparation when you're thinking about a specific study to do. That's the water going down. First of all, you have to think about the feasibility. And, the hardest thing with clinical research is actually getting done, getting the patients enrolled, and identifying the barriers as early as possible. Remember that when you look at clinical trials in the United States, if you look at multi-center trials in particular, fully 30% of study sites that sign up in a trial will never enroll a single patient, and 70 to 80% of study sites will markedly under-enroll relative to their expectation up front. And something like 30 to 50% of trials are terminated on enrollment only. So feasibility, obviously, the system overall isn't that great at identifying non-feasible trial concepts. So it's important to give it a lot of thought up front because you don't want to be wasting your time. So you need to think about what regulatory hurdles must be jumped in terms of does it need to be an FDA-monitored study? What other issues are there? What's the pathway by which you're going to identify study participants? It's not enough to say, well, there's 700 DVT patients in my institution. What you have to figure out is, where are the patients? How are you going to get at them? How are you going to know they're there? How are you going to know they're there and get at them before 7 other doctors have talked to them about treatment options? And that's a lot harder than it sounds, actually, and it depends a lot on what disease you're studying. But one of the unique things about interventional radiology is that so often we aren't the frontline caregiver. And so it's not like a cardiologist enrolling patients with acute myocardial infarction where all the MI patients come to the cardiologist. For us, for most of our diseases, patients go to an oncologist, patients go to the vascular ultrasound lab to be diagnosed with their DVT, they go to the emergency room, they go to other physicians. And so getting yourself into the front line is a very important thing to think about up front. You need to think about the burden of a study. What burden does it add to patients, their caregivers, their physicians? If you're expecting their physician to do a lot of work to help you enroll a patient, you got to understand that's not going to happen in real life practice. Everyone's incredibly busy. Think about your own partners. If you're expecting your partners to come in and do lysis follow-up procedures on Saturday and Sunday, well, you got to work that out with your partners. It may or may not be possible, right? And so thinking about what burden does the study add? And then also thinking about what competitive treatment options are out there and what other studies are ongoing in your institution. That's also important. If you've got 4 studies that are enrolling patients with the same disease, it may or may not be the easiest thing to pull off. And then finally, you just, the real core underlying truth is that both the study and the intervention that you're studying, they exist in the real world of clinical care. And the real world of clinical care is incredibly messy, and it requires a lot of thought as to how to navigate it. You really have to think about why physicians would want their patient to be in your study. I think other things, again, we're talking about doing trials that compare typically interventional options versus either medical or surgical options. And remember that that's a huge difference. That's very different than saying, here, either take Prozac or another antidepressant for your depression. We're going to randomize you. Either way, that's one pill once a day. The patient's doing the same thing. When you talk about having a major procedure with risks versus not having a procedure, patients are going to have a lot of strong feelings about that. And the willingness to be randomized, it's much, much harder. And so it's very important to remember that when you're doing these kinds of studies, you really need to think about how you're going to present this in a balanced way. Similarly, remember also that when you're studying new treatments that are not FDA approved, one of the advantages is that people can't get that treatment unless they're on the study. On the other hand, if you're looking at procedures that are available in clinical practice, and remember, because of the FDA's 510K mechanism, devices get approved very quickly, even before they're really proven to do much of anything. Oftentimes, these treatments are available off-study, and so a patient can simply choose to have the treatment off-study. And so again, all the more important to present things that benefits the risks in a balanced way. It's important to be inclusive with your eligibility criteria because at the end of the day, you want to be able to generalize the study results to the population of patients that could actually be treated with that intervention. You don't want to cherry pick too tightly because you're really going to end up hurting your enrollment, and then also you're going to have issues with generalizability. And it's very important as an investigator that you really need to take responsibility for communicating your enrollment plan to your colleagues and to other stakeholders that can help you. So again, for DVT, that vascular ultrasound lab where DVT is diagnosed is a very crucial location. The emergency room is a very crucial location. Every month I've got to be making contact with them, maybe every week, to just remind them that the study is ongoing. We appreciate your help. You guys are awesome, et cetera, et cetera, et cetera. Again, we've talked a little bit about this already. There's many modes of failure of clinical studies you have to think about. Access to patients is a big deal for IRs. Improper exclusion of patients. You got to look at the eligibility criteria, make sure people understand them. Again, informed consent. You always, of course, you're going to do things in the most ethical way possible at all times. But that said, there are ways that there are practices that are better in terms of framing a study and choices to a patient as opposed to making it pretty much 100% likely that they'll say no. And then you also want to consider issues with insurance coverage costs, and then clinical equipoise we'll talk about, and then also crossover. When you're signing up a patient, it's important for them to understand that if you're signing up for the study, we'd like you to remain in your assigned treatment arm for the duration of the study. Again, attention to retaining patients is important. The biggest key to that is when you design a protocol, you design it to be very lean. It's very tempting to say, oh, well, since we're doing the study, we're going to get 7 other measurements or have the outcome measures, whatever it is. But remember, when you do that, you're just reducing the likelihood that patients will even come back for those follow-up visits. And you're really burdening you're burdening patients, you're burdening the research teams, and you're burdening, and there's a cost element as well. So you want to limit the number of non-essential assessments of doing a study. In terms of informed consent, I think that keeping your explanations relatively brief and letting the informed consent document do the talking is one very important thing. I think it is important to address all the patient's questions, of course, and really convince yourself that the patient is comfortable about being in the study. The involvement of the patient's primary physician and their recommendation for the patient to participate makes a huge difference in helping you enroll patients, so getting them on board is helpful. And I think it's important to know your value proposition. And remember, in the ATTRACT trial, what was interesting is that, again, this was a trial of 2 treatments available in clinical practice. One of them is new and fancy, the thrombolytics, but again, these treatments are available in practice. And so at the beginning, many of our investigators started out by really trying to sell the patients on how exciting the new lysis treatment is. Well, if you do that, you can't expect them to want to be randomized. And so, again, what's the value proposition? Why would a patient want to be in? And for the most part with clinical studies, the #1 benefit is close monitoring by the study team. A study is really a structured program of quality care, if you think about it. And that's a very, very important thing. You're not going to tell them that they're going to get inferior care if they're not in. That would not be a kosher thing to do. But certainly you can emphasize the fact that within the context of a study, what we're doing is really monitoring you closely. And patients find that to be very attractive overall. Sometimes if you're doing an NIH study, you can tell patients that you're going to get the best of the best in terms of the study protocol and the experts involved. In many studies, you're going to provide them free care items, whether it's imaging studies or devices or whatever. In some studies, there are financial incentives as well. But the key thing is to really just think about it up front and understand what's the value proposition, why would a patient want to be in. When you talk about selecting outcome measures, again, very important to reflect clinically important disease. Ideally, you want it to be the accepted standard for measuring the disease that people have already referred to in the literature, to the extent that that is compatible with an imaging-guided intervention study. Sometimes you're doing something that's just so new, and in the world of previous medicine, people really did look at things the same way, and you have to make some adjustments. But overall, you want to rely on accepted standards when possible. You want it to be objective to the extent possible. And nowadays, a lot of trials are combining patient-reported endpoints that have a subjective component with objective endpoints, that can be, for example, assessed by a blinded assessor, to really give you the best chance of minimizing bias. So you've got both. And again, you want the measures themselves to be acceptable for use, meaning easy to use, reliable, valid, and responsive to change. And that's its own lecture in itself, the validation of these kinds of measures. And again, it has to be something that's statistically testable, the primary outcome measure, because your sample size of your study is going to be determined by the statistical hypothesis you make that relates to the primary outcome measure. Again, clinical equipoise is an important thing. If you're talking about randomized trials and you're going to enroll someone and randomize them, ethically, there really has to be doubt as to which is the better treatment. Otherwise, it would not be ethical to do that. Now, at a national level or at a large global level, for many clinical questions, there's plenty of doubt. The hard part comes that when you take it down to a local site, look, every one of us as a physician, we're opinionated people. And even though I might say, okay, well, yeah, it would be great to have a randomized trial to decide, whether or not people with DVT should be thrombolysed or not, remember that when I'm presented with a case, 95% of cases I have an opinion on whether they should or shouldn't be lysed, right? It's only the 5% that I honestly throw up my hands and say I don't know. And that's true for any physician out there. And so what the hardest thing is with some of these image-guided intervention trials is that you have proceduralists that are very much on board with the intervention. You have medical physicians or neurologists or physicians that don't do the procedures and don't make money from the procedures, who are a lot more doubtful about them and maybe more concerned about their risks. And so even though there's national equipoise, at the local level, which is the level at which you're actually interacting with patients, you may not have equipoise among individuals, right? And so one thing that's very important is you have to be active in coaching everybody to really try and maintain as much balance as possible in how they approach the study, both in terms of interacting with patients and just, assuming a balanced posture towards we don't know the answer, and that's why we're doing this together, And, some of the real-world consequences of that, if you think about it, in the ATTRACT trial, here's a patient with a big left iliofemoral deep vein thrombosis from what we call May-Thurner syndrome. There's a narrowing in the left common iliac vein. This is considered the best type of patient for thrombolysis, really, what we would call a slam dunk. And many of our investigators up front were very hesitant about randomizing these kinds of patients in the study. Why? Because if they randomize to the control arm, they don't get lysed, and they were worried that that would be substandard care. Well, it took a lot of effort, but we were able to convince most of those investigators that, well, But then again, you got to consider the risks of thrombolysis. 1 in 100 times or 1 in 200 times, patients have a devastating bleeding complication, right? And so it's not so clear that it is, going to be a slam dunk for everybody. And then the other thing is that if these are the best patients and we take them out of the study, we're basically increasing the likelihood of a negative study. And a negative study, if the treatment doesn't work, is fine. A negative study, because we took the best patients out of the study, that's not okay, because you're not really then simulating what would happen if you used the treatment in practice. That's a bad thing, right? At the other end of the spectrum, there are patients that have more minor DVTs in the study, who may be 75 years old, higher risk of bleeding, a little bit sicker patient, and some of our investigators might have been inclined, well, you know what, I'm not going to enroll that patient. In my practice, I wouldn't thrombolyse that patient. Well, but on the other hand, if we take these worst patients off the study, what's going to happen? What if you do the study and you have no complications in the study, but then you go and in the real world, people apply the treatment to these kinds of patients? What's going to happen? You're going to have 10,000 bleeding complications, right? That's the worst possible outcome of a study, is that you pronounce the intervention safe, and then the intervention gets applied to 1 million people later on, and it's not safe, right? So again, very, very important to, once you define eligibility criteria, you really do want to adhere to them, and you want to work to convince everyone to adhere to them. That's really what an investigator needs to be doing. So I'll get to some issues of real-world conduct of a study. Again, it's a messy clinical world out there. For the disease that I deal with, anticoagulation, it may be that I say they should receive this treatment or that treatment, but the reality is their insurance company determines what they get. Patients can't get it even if I say they're going to get low molecular weight heparin, they don't get it. They get whatever their insurance company allows them to get. So it's silly to proscribe in a protocol what drug they're going to get sometimes. We know that the INR monitoring in the United States is not done very well. DVT patients can be on anyone's service in the hospital. It's not like it's a disease that's centralized. So you got to think, if you're studying a disease, where are those patients going to be? Whose service are they going to be on? And who's going to be managing them? Because for them to stay on protocol, you're going to need to get buy-in from the people that are caring for that patient. And then, again, there's lots of reasons why your intervention may or may not be practical to do. A patient may need to go home for a while for their own reasons. Doctors may be unavailable. It could be the weekend. There's a million reasons why someone may not be able to get your intervention. So when you design your protocol, you really want to write it in a broad way that accommodates, has that kind of flexibility, So you want to consider the real world issues, consider the daily lives of patients that have the disease, weekend issues, backup systems, etc. Don't be proscriptive unless you absolutely have to. So if something is truly a drop dead safety issue, yes, then you say don't do X in the protocol. But you want to be very careful about it, because the protocol is a rule book. And if someone violates the protocol, you need to call them out as having committed a protocol violation, which is its own big deal. And so if your intent is that you're going to allow some flexibility, write the protocol to allow that flexibility so you don't get into trouble later on. Again, blinding is a very important thing. In general, for almost any clinical study, if you're not going to do blinded assessments and double-blinded assessments, that should be justified. And in image-guided intervention studies, oftentimes doing it double-blind would require a sham procedure, which is usually considered unethical for most types of interventions. And so that's fine, but you do want to be thinking about that. The FDA is convinced that about 1/3 of treatment effect in clinical studies is the placebo effect. In other words, a patient knows they're getting a particular intervention, and their outcome, to some extent, there's the subconscious psychological effect that results in them having better outcomes. And so very, very important to try and account for that by blinded assessments whenever possible. And again, blinding is not just about, it's about ideally the patients, although that can't always be achieved. Certainly the investigators and staff don't need to know what a patient is randomized to beyond the period of time when they receive that treatment. So in ATTRACT, for example, we do thrombolysis in the first few days in half the patients. But beyond the first few days, for the remaining 2 years of follow-up, we don't need to be talking about what arm the patient is in. We should be managing patients really the same way, and so we don't really need to be talking about it at all. Similarly, the outcomes should be assessed by blinded assessors whenever possible that don't know what treatment arm the patient's in, and adjudicators of clinical events, the people that read and review the vignettes that decide, does this count as a major bleed? Does this count as a recurrent pulmonary embolism? Whatever it is, need to be blinded as to which arm the patient is in. That's going to give you the best chance of minimizing bias. Randomization obviously minimizes bias by preventing selection bias of patients. So by knowing patient characteristics, you can't direct them to get one treatment or another. That needs to be obviously described. The patient needs to understand it. Intent to treat is an important principle to really abide by. Remember that once the patient is randomized into a clinical study, they're going to be analyzed in their allocated treatment arm, period. And you really want to avoid taking patients out of studies after randomization. And if that's going to occur, you really need to pre-specify what criteria will be used to do that. Similarly, when it comes to follow-up, it's very important to remember that you want to report the outcomes of everyone that was randomized in the study. And anyone that you lose to follow-up, that's really a loss to the study. And remember, it's important because, if you lose 10% of your patients in follow-up, well, how do we know those patients didn't die? How do we know that those were the patients that had the worst outcomes and therefore they couldn't come back to their clinic visit, right? Or they were angry about being in the study because they had the worst outcomes. And so people can assume the worst. So it's far, far better, even if someone says, well, you know what, I'd rather not continue to receive the blood thinning drug, and I choose not to receive it. Even if they choose to not stay on protocol and they insist on that, and you have to sort of accommodate them, still encouraging them to continue in a study for follow-up is helpful, because then you can at least say what did happen to that patient transparently. And that's a very, very important concept. If a patient withdraws their consent actively to be followed, that's different. Then they're out of course. You always are going to respect that. But if they don't withdraw their consent, really, they're in the study. Crossover is a big problem with clinical studies. And a lot of this again gets to the idea of the mindset of an investigator. So in clinical studies, especially interventional studies, patients who randomize to the control arm at some time point if their disease worsens, because they know about the other treatment, they know about the intervention they didn't get, may be asking about it and saying, well, why can't I get the stent now? Their doctor similarly may feel they got worse. Why can't we give them the stent now? Well, the problem with that is that when you cross the patient over, you badly degrade the power of the study. And you're basically going to be salvaging patients in one treatment arm that would have had a bad outcome, that would have been registered as a bad outcome, right? And it creates all kinds of problems. And so it's very, very important. Now, obviously, there is a point of disease progression at which it's unethical not to cross someone over and allow them to have whatever treatment they need. And of course, that you want to define in the protocol, and when there are exceptions that need to be made, you want to make them. But that shouldn't be something that can happen willy-nilly, because that will badly degrade what you're doing. And one of the important parts of that is, again, the mindset of the investigator is you need to train the people you're working with to approach things and to think about this in a balanced way. When a patient comes back and says, well, my leg is more swollen, I want to get lysed now. Well, let's think about that. First of all, the clot's now 6 weeks old. It's not likely to lyse anymore. Secondly, we don't know if lysis works in the first place. Thirdly, the risks are still there. So even though it may sound logical that I want more, maybe it isn't the right thing to do, And so it's important, again, to be encouraging the investigators and study staff to be thinking in those ways and talking in a balanced way about the different treatments with the patient. Again, you want to standardize assessments whenever possible, standard criteria, etc. Same thing with the outcome adjudicators. You want to have specific criteria for tumor recurrence or whatever it is that's your outcome, so that things can be administered in a standardized fashion. And again, it's really the responsibility of the PI to really focus in on the sense of balance in all aspects of what you're going to be doing. It's that demeanor and leadership and sensibility about bias that really defines someone who's a promoter of procedures versus someone who's an investigator. You want to conduct a fair study. It's also important, and I think that many people that aren't formally trained in research don't realize that, again, as an investigator, you have responsibility. You're responsible to ensure subject safety and study integrity. You're responsible for reporting adverse events per federal and IRB guidelines. And it's important to make sure that you educate the people around you that that's serious business that absolutely has to be done. again, the protocol and the informed consent document are a contract, really, between you, your IRB, and the patient. They're giving you permission to do research on them under the contingency, under the condition that you're going to follow this protocol that's been reviewed by the IRB. So if you're going to deviate from that protocol except to prevent immediate patient harm, you need your IRB's permission to do that. So to conclude, I think succeeding in research, it involves different aspects. I think preparation is a big deal. Understanding your clinical practice, learning what research sources are available, finding and cultivating mentors, and developing the technical and collaborative sort of skills that go around research that are different than clinical practice is important. You need to be adaptable, learn from different mentors, realize that clinical practice and clinical research are pretty messy, and use your mistakes to learn more. And then finally, of course, you have to be passionate about what you're doing. So I'm going to stop there and maybe take some questions.
Dr. Vedantham, thank you so much for going through all that. That was very helpful. We have had a few questions come in over the course of the lecture, and I'll just read them in order. So the first question is, I'm a beginner in research, and I want to know from where can I start? What are the required skills to get started?
Okay. So I think that, obviously it depends where you are. I think that most universities have a set of core training courses that they give. And some of them are very quick kinds of things. You go in for an hour or two. Others are more course level. And I think one thing to realize is that we tend to be very siloed. I'm in a radiology department. I see what happens in interventional radiology pretty clearly. I see what happens in radiology a little bit less clearly. Beyond that, I don't see a whole lot because I'm very busy with everything that I do in my daily life. But remember, first of all, there are a lot of resources available, certainly in university centers, to get those kinds of experiences and to learn from researchers in terms of, basics of constructing a study, basics of sample size, and thinking about how you design the very basic core elements of a study. There are a lot of courses so I would, first of all, investigate A, your research administration in radiology, and then B, the university's central research unit. And usually those courses are available. There are also, sort of talks and all that at the SIR meeting and other places, but I think the more serious ventures we found in the universities. I'll mention, too, that for some of you that are really motivated about it, we need researchers in IR that are well-trained. In other words, people that have gone out and gotten master's degrees in clinical investigation. There are MSCI programs at many universities. It'd be great to see, or masters in public health or epidemiology that teach kind of formal research methodology. It'd be great to get more people that are seriously trained, and so it kind of depends on how much time you're willing to devote and, and what type of thing you're after in terms of time availability.
Okay, and so our next question is from Rajat. In terms of groupthink, when attempting dialogue with experts at your institution, what would you suggest if the paradigm at your institution is such that the area of research which you intend to pursue is dominated by another specialty, such as vascular surgery? How do you go about the dialogue among specialists at your respective institution? Yeah.
One thing I've found is that when you get to actually, one thing I found is that in working with surgeons and working with physicians from fields that may be competitive with ours at a turf level, when it comes to students, trainees, helping each other with research, mentorship, I've never found subspecialty to be a major barrier. And it's shocking, really, really just because I think in everyone's fields, people really appreciate the importance of mentorship and the importance of helping people that are coming along, So the first thing is don't let it be a barrier is what I would say. Now, the second thing is that in terms of how you talk about the disease and how you talk about the procedures, you want to exercise a little bit of care in the assumptions you make. For example, when I was a fellow, we did, and I happened to work with Mike Dake, and so we did thoracic stent grafting, and it was done in the interventional radiology suite at that time, and the surgeons would come over and cut, and we would actually percutaneously access the vessels, put the stent grafts in, and then send them back to the OR for the surgeons to close up. What I didn't know was that that ain't the way it's done everywhere, and so when I came here to Mallinckrodt, at the beginning, I was sort of shocked by the whole thing, that the surgeons were really more or less in the driver's seat for a lot of things, which was actually the norm, really. And so I probably stubbed my toe more than once, just not understanding that. And so I think that you do want to be a little bit diplomatic in how you talk about these things. Remember that, we have our perspective on why turf should be ours, but they have theirs. And, ours is that we really, in terms of doing procedures and having the imaging ability to really be very refined in doing them, we have a big advantage there. But others have a big advantage in their understanding of the disease processes. I hope it won't stay that way forever, but that is the reality now. And so remember that everyone has a claim. The important thing is who does it well. And if you approach it with that mentality, I don't think you're going to find that there are major barriers to getting mentored by other physicians.
Thank you, Dr. V. The next question, can you elaborate on how you decided to concentrate on DVT? With so many intriguing areas, why DVT? A combination of opportunity and interest?
Yeah, that's one of the really, what's interesting about that? Well, I guess there's 2 points I think that are important about that. The first is that early in your career, you'll be given opportunities to write review articles, participate in all kinds of things, right? And I think it's important to, at the beginning, have a say yes kind of posture, because just writing a review article, it takes you to such a different level in your understanding of something, and while you're doing it, you're just like, my God, why am I doing this, But then when you're done, you just know so much more about it, and it helps you clinically, it helps you develop research areas, and that happened to me, and I wrote 2 review articles when I was a fellow. One of them was on DVT. The other one, and believe me, when I went to write my NIH grant, my God, it was helpful. And then 2, I wrote about aortic dissections. And the funny thing about that was that 3 months into being an attending here, we had the most horrendous case of an aortic dissection come along on a night that I was on call. It was 2 nights before Christmas. And I was able to manage that. And I think just my fellowship training probably wouldn't have been enough, but I actually had read a ton about it. And so I knew a little bit more than I would have otherwise. Now, the second part about this that's really important is you said combination of something and opportunity, and that is even more important. Remember that you're going to have a research direction in your mind, maybe, but until you go to an institution and scope out the environment there, how feasible your chosen direction is, you will not know. And, so when I came to, at UCLA when I was a resident, I was involved with the first, Scott Goodwin was the first sort of IR in the United States to do uterine fibroid embolization, and I was part of that group, and I wrote the first paper on it, and all this kind of thing. Was pretty exciting at the time. Then I went to Stanford and got trained on stent grafts. So when I came here, I thought, okay, I'm going to be the fibroid and stent graft guy. Well, as it turns out, for various different reasons, the avenues for development for me in those areas really weren't as open as I thought they were going to be. And so, but because I had a pretty diverse skill set and I had other things that I just knew something about, DVT being one of them, it just turned out that I evolved into that area. So, when I entered as a faculty member, I didn't have a burning interest in DVT. That evolved actually over time as I knew how to do the procedures. I was trained by people that did them, and then I started getting involved with the patients, and then people started looking at you as a point person in the area, and then it becomes more interesting as you go along. So I think the 2 things are, 1, take the opportunities you're given to to develop kind of an advanced knowledge base in specific areas up front, and then 2, be a little bit open-minded and realize that you're going to have to be flexible. That's just the way the world is, when you come out.
Great. Our next question is from Keith. With regards to the previously mentioned university courses, are there any online or paid courses beyond the university realm?
Good question. I believe there are. I think that, so some of the more advanced sort of serious clinical trials investigation courses. I think Hopkins has one. I think, what's the other one? Oh, there's one more. I think Harvard might have one, but Hopkins I know has one. And I think they have developed an online resource. The other thing is that the NIH funds specific research companies sometimes to collaborate with NIH researchers in doing different kinds of projects. And as part of that, they'll often develop online resources, you know. And so, for example, for the NHLBI has a company called RTI International that has developed a really cool website that has all kinds of resources about helping investigators develop clinical trials. And if any of you want, you can email me afterwards, and I can dig that up for you and send you the link. But there are actually resources in terms of doing that, and there's probably more I don't know about too, to be honest.
Okay, our next question, there are two from Dana. The first one is, do you have any advice or tips on how to find a good mentor to guide you through research? And the second question is, how do you feel the NIH funding environment is since recent significant cuts? Has it still been conductive doing research, or has it become increasingly difficult?
Right. Well, finding a mentor is, you know, I think that chemistry is important, and I think that you have to be comfortable, in talking to someone, to a mentor. Again, the key points are responsiveness. I mean, everyone is busy. Some people will still find time to be responsive to you, and then, of course, also determining, and coming to your own judgment as the degree to which someone is interested in what you can do for them versus what they can do for you. And I think that some people really are focused on understanding what you want out of your career, and trying to help you get there, whereas others you'll find pretty quickly have their idea of what they want a student or a trainee or whatever to do. And again, there's give and take, and you have to be open to that. On the other hand, you want to really make sure that that you look at that. I would advise sticking with the associate professor level or above in terms of that as well. Because one thing is that if you're at an assistant professor level, publishing is a survival thing, and so I think it's a little bit harder to. You could get into a situation where you don't get full credit for the work you've done if you have a more junior mentor. And also, I think their overall perspective on how you get from point A to point B to point C in your career, it's just not as mature as someone who's been around a little bit longer, And that's not, and I don't want to say that's there are some fantastic mentors that are younger, and so I don't want to say that's the be-all and end-all, but you do want to give that a little bit of thought, finding someone that's a little bit more further along, but who will still give you their time. Oh, in terms of the NIH cuts, well, the good news is for 2016, the appropriations, the NIH budget was increased by $2 billion. Wait, $2 billion? Can't be $2 billion. Yeah, $2 billion to $32 billion, which is the largest increase it's, I think, had in over 10 years. Now, that's just 1 year, of course, but it always goes back and forth. The pay lines are very difficult with the NIH, and the reality, the NIH process, I'll tell you, it's a double-edged sword. On the plus side, if you are able to get funded, the difference in your career, the level of credibility that you get out of that, and the opportunities it leads you to. I mean, in other words, once you're funded for something at the NIH and people know it, you really are you're considered an expert, and people invite you into all kinds of panels and this and that and everything, and your opportunities for career development just grow exponentially. Now, there's a huge price to pay, though. The NIH process is hard, no doubt about it. You work very, very hard. And what I would advise for the NIH is that, the NIH talks a lot about, cultivating new investigators. And it is true that they sort of try and do that. On the other hand, the reality is that in a competitive funding environment, the people they know are the ones that get funded. People who have been funded before, it's easy to get funded again, or easier to get funded again. So I think that one thing is that you do want to surround yourself with, a mentor that has been funded. Trying to do it solo, I think it would be very, very difficult, because just the way you approach an NIH process, is different. Now, there are a number of good grant writing courses out there. There are a number of, the RSNA, for example, has a good grant writing course. The RSNA also has a clinical trial development course. That's pretty cool. You kind of come in with the clinical trial concept. You hole up in a hotel for a week, and there is a whole bunch of mentors around, and you divide up into groups and all that, and you really put your own trial through the process of how would I develop this clinical trial out, And I think if you're talking about a serious process like an NIH process, I think it would be helpful to go through a program like that, because it really will help you step up your game kind of to the level you need to be at to get funded for the NIH. But don't be afraid of it. I mean, I want to say this. Don't be afraid of it, because I tell you, we need IRs that are in the NIH world, because what you get out of it is that, again, with IR, one of the challenges is that we're often not at the table where decisions get made, whether it's panels at CMS, whether it's the FDA, whether it's wherever. We need to be at the table. And one of the best ways to get to the table is, if you're an NIH researcher, the more of them you have, that makes it 100 times easier, to break all the barriers down, And so I encourage you, and anyone that wants advice on that process, I'm happy to provide it offline as well.
I think you partially answered this question earlier, but can you speak more to what steps you took to move from a well-trained IR to a place where you wrote a grant for a large multi-center trial?
Yeah, I tell you that I don't even know, so what happened was that when I wrote a few small articles, kind of the types of articles that are pretty typical. You did 20 cases of something, and you wrote it up and published it in JVIR. So I wrote a few retrospective review type articles on DVT. In the process, of course, I had to read the literature more and more. And after that, I think that I was asked to chair the DVT Research Committee by the SIR. Now, what's funny about that was that, being asked to chair the DVT Research Committee, it's like being asked to chair the, English Cuisine Committee. There was no DVT research going on, but it wasn't really viewed as a high priority thing either, But I think what I did was I got people together to talk about what are the research priorities and where do we need to go. And honestly, when I started, my idea was that I thought we would probably need an NIH trial, because industry clearly wasn't going to step up to the plate. But I kind of thought I was going to set it up for someone else more senior to do. What happened was that in the process of being the person that put in the energy to bring everyone together, and again, we brought people together from within IR and also outside interventional radiology, people started to see me as the mover, I think. And then when it came time to say, okay, well, let's do this, I turned out to be the person that, and again, I think part of it was that the senior people, they probably could have done it, but they felt it was a pretty hard process, with a lot of uncertainty associated with it, I'll say that I had a lot of help in the sense that here at Mallinckrodt, we have some administrative people that are tremendously helpful about grant writing. In other words, the science parts of the grant you write, but the non-science parts, then there's a lot of them, they draft and you edit, And so I had a lot of kind of administrative support to do the mechanics of the grant writing. And also that came with a lot of advice too. In other words, what I didn't have was a research mentor on site with me here. As we've got some amazing people here, and I have some great clinical mentors, but none of them was my DVT research mentor. I found that myself by going outside interventional radiology. And I think what helped a lot was the SIR Foundation, frankly, because we started out with the research consensus panel, and I think that gave you a little bit of a leg up, because then you had people outside the field saying, okay, well, he's the guy that that the SIR Foundation supported, so maybe he's someone who's worth working with, and that enabled me to at least get some face-to-face time with people that could be helpful to me in terms of mentorship and guidance and all that, And it evolved, and it was a hard process. It wasn't an easy process. I mean, I learned a lot of things along the way. I was helped by the fact that Tim Murphy, who is a past president of SIR, who's an interventional radiologist, he had gotten some NIH grants before I did. And so having him help, and just sort of talking to him about things helped tremendously, and just getting a sense for what the NIH is like. Because look, all of us throw in grants to the NIH that don't get funded. They're tons of work and they don't get funded. And it's a lot like baseball. If you're a great hitter and you have a great year, you bat 300 or 330, you know? I mean, that's what it's like. It's 1 in 3 if you're really good at it, you know? So it does take a lot of commitment, but I'll tell you the payoff is tremendous. And honestly, you know, having the sense that you're doing something that really is high-minded and balanced, and that is most likely to give you a result that mimics clinical practice without bias, I think that's just so important. Because, look, I mean, I love a lot of the other stuff that's going on in our field, but a lot of it we have to accept is set up in a way that doesn't minimize bias. And we want patients to get the answers that are correct, you know. So I don't know if I answered the question properly, but.
No, great. Thank you very much. I know we don't want to keep you too late. We have 2 more questions if you're okay with it.
Sure.
The first one is, what are the best resources to know the hot topics of interest in IR?
Well, there are, I mean, gosh, I wouldn't, there's so many hot topics, you know, and hot is a matter of perception, right? So, you know, different people are interested in different things. I'll tell you, when I think about our field and I look at the future, I don't think about, I mean, I think about, you know, the fact that it seems unlikely that in 30 years, someone will let a human being take a needle and shove it in the body. In other words, these are things that can be done much more precisely by computers and robots, probably, right, without the error. Now, again, that technology is coming along. We now have robotic sort of liver tumor ablaters, you know, that exist already, and there's going to be a lot more done there. So robotics is a big thing. The melding of health information technology with IR. I mean, if you think about it, so much of what we do, the effectiveness of it depends on things that are happening to a patient, not when they're in our office or not when they're in our procedure room. It's when they're living their daily lives, right? So connecting up IR procedures and outcomes to a patient's life by giving them the ability to transmit information about it. Obviously, a lot of work is being done in that area. You know, you get your Apple Watches, and you know that's just sort of the first step, right, in that kind of direction. You know, there's a lot going on in nanotechnology, in small molecule technology. You know, the ability to target different molecules in the body in ways that we couldn't before. There's just a lot of stuff, and so I'm looking at it in that way. Now, from a procedure standpoint, one thing you have to understand about IR is that it will blow your mind. Every year or two, some new thing comes along, and it'll be a common disease that somehow someone has figured out that we can treat with some procedure. You know, 10 years ago or 20 years ago, it was uterine fibroid embolization came along. It was like, my God, you know. And then there was, you know, there's you know, the neuromodulating therapies for hypertension, for example. There's just so many things, you know. I think we'll have I think in a few years, especially if the ATTRACT trial is positive, I think we'll have better drugs to lyse clot, that hopefully drugs that don't cause bleeding, you know. We'll have new principles and ways to dissolve clots, maybe ways to, there's a lot of work being done in bioengineering of bioabsorbable scaffolds for veins. So instead of putting metal stents in, you put in something that emits a compound that prevents intimal hyperplasia and prevents thrombosis, and also naturally grows into the vessel wall, you know, and promotes healing, you know. So there's a lot of work being done in those kinds of areas. So, but I mean, you know, this is just the small snapshot. Every year or two, now prostate artery embolization is being carefully evaluated for its ability to treat benign prostatic hypertrophy. There's just so many things that every time you go to a meeting, you're just shocked at what someone has come up with, you know. Plantar fasciitis. There's some sort of ultrasonic therapy that interventional radiologists are using to treat plantar fasciitis. I mean, it just goes on and on, really.
Yeah, Dr. Vedantham, our final question is, you mentioned weekly communication with the ER. What specific responsibilities does a national PI have in a trial like yours?
Well, so keep in mind the ATTRACT trial is pretty complicated. It had 56 clinical sites around the country. We had 2 core labs, a data coordinating center, multiple investigators at each site. So a very complicated study. A PI has a lot of responsibilities, but I think that the number one is you have to be constantly communicating and responsive to people. Because when you're, interventional versus medical trials, they don't tend to enroll 10 patients a day, They might enroll a patient every 2 or 3 days around the country if you have 10 or 20 sites. And so what that means is that people are implementing a complex protocol infrequently, which means that they're going to have a lot of questions. And if you want to avoid mistakes being made, you have to be highly responsive. You need to be, the biggest thing is you need to lead by example. You really need to, people follow, people take their cues from the leader. If the leader's attitude is that we're here to prove that lysis works, you'll find all kinds of things happening in your study that you wouldn't maybe want to be happening. If people sense that the leader is hell-bent on conducting a fair trial and hell-bent on making sure that we're all working as hard as we need to respect our patients' sacrifices by making sure that we enroll the trial, making sure that we do the right thing, making sure that we work hard to follow them, etc., then people will follow along, So when you say what's the responsibilities of a PI, I could go on and on. You have to do site monitoring. You've got to report and, report to the FDA, report serious adverse events. You've got a million responsibilities, but I think the one to think about really are leading by example, and communicating a lot and being responsive. Are we still on?
I'm still here. We might have lost Lindsay, but that was the last question in any case. I guess I'll close out. Thank you so much for coming today. That was a really great talk. I think we all learned a great amount. So thank you for sharing your time with us.
You're welcome. Thanks so much.
All right.
All right, Dr. Cut out. Thank you very much. We really appreciate it.
No problem. Thanks a lot. Take care.